Some people will call it adult respiratory distress syndrome, acute respiratory distress syndrome. These folks can't breathe. And this is serious. This is probably one of the most serious things that you'll ever deal with from a respiratory standpoint, because these people are SAS. They are sick as snot. Now, we talked about hypoxemia, right? Which is what? It's a inadequate arterial oxygen, right? So we are not perfusing. We are not oxygenating, okay? The difference between Ards and most of your other pulmonary issues, the hypoxemia persists even with 100% oxygen. What does that mean? You can give them all you want, and it's not going to help. That's exactly right. Because you'll see these patients, you put them on 2 liters, and they're sat in 88%. So you bump it up, you call your doctor, and you go, this ain't working. We'll bump it up to 4, 6, or whatever. Still ain't working. So then how much can you run through a nasal cannula? 6. Then what do you go to? A face mask, a simple face mask, right? What's the highest you can go on a simple face mask? You can't go to 20 because it don't go to 20. 10. Okay? All right, then what's next? A Venturi mask. And you can go to 15 or 12 on it, but it's all dependent on your settings on your mask itself. Then what do you go to? A non-rebreather. Y'all remember you need to put oxygen, a little baggy thing, hanging up under their chin. Because if not, it ain't working for one thing, and 2, that lets you know that you've connected oxygen to it, because if you put that on their face without it, you can kill them. Because all you're going to do, it won't allow them to breathe in. So, like I said. But anyway, you always need to know what type of oxygen and how much is given for each of the devices that you have. What's after that non-rebreather when it ain't working? BiPAP. What's after that? Intubation. And we'll talk about that in a minute. But the biggest thing is, whenever you do that with the CPAP, BiPAP, APAP, DPAP, non-rebreather, half rebreather, full rebreather, it's not going to improve their oxygenation status because you have decreased pulmonary compliance. Ooh, that sounded bad, didn't it? What does it mean? The lungs are not working, okay? So when we talk about decreased pulmonary compliance, we talk about stiff lung syndrome. How many of y'all have ever had, you get those balloons out of the pack, and they're real, well, they're tight too, but they stretch, right? Set that bad boy out in the sun. What happens to it? It dries out, and if you try to blow it up, what happens? It pops because it doesn't have any compliance left. Well, the same thing happens to your lungs. Okay, then they have that, is that dyspnea or dyspepsia? What's the difference? What is dyspepsia? Heartburn. They ain't got heartburn. They got lung burn. They have dyspnea. They're short of breath. They have non-cardiac associated pulmonary edema. Okay, what if they had cardiac associated pulmonary edema? What do they have? Heart failure. Guess what? This ain't it. They've got fluid infiltrating from another reason. It's not their heart. And they have dense pulmonary infiltrates on an x-ray. What's it going to look like? White. Why white? What's black on a lung? Air. Well, guess what? The air ain't there. So you're going to have this, they talk about a ground glass looking x-ray. How many of y'all saw x-rays from COVID? Same thing. Except COVID had a lot more mucus in it, but that's a whole different issue. But that's still, you treat it the same way. They are in distress, and they need interventions now. Okay? Y'all got that? Oh, look, another video.
So your patient is an Ards, acute respiratory distress syndrome. Fancy words for there's just massive alveoli inflammation, and your alveoli have collapsed, caused by instability in terms of the alveoli structure itself. So after this alveoli, if you guys don't know what alveoli is, it's just the end portion of your respiratory tract itself. It's almost like the apples on the tree of your lungs, pretty much. That's where all the action happens. We exchange our oxygen for our CO2. You breathe out your CO2, you breathe in oxygen. That's where that exchange on the capillary beds happen. Okay? So, your actual alveoli have collapsed, and a mass of fluid has now rushed in to your respiratory tract, to your alveoli. Now there's fluid being rushed into the respiratory tract. So what do? How do we make sure that we're decompressing, de-inflaming our respiratory tract? Some things we can do is we're going to give steroids. We can do corticosteroids. Now, what's a main one that I tell you guys about in BAM and SLAM? Yes, that's correct. Solimedrol is a corticosteroid. You can also use prednisone, which is a corticosteroid. Load people up with steroids to bring down that inflammation inside your respiratory tract. This is going to decrease inflammation, obviously. And it's also going to decrease the movement of WBCs. Because if you've taken my pharmacology boot camp, you guys would know that steroids decrease your immune system, your immune response. So that's one thing that it's going to help stop the movement of these WBCs into your lungs. Another thing is, we have fluid pooling in your lungs, right? So think about your house. Think about the community pool. I don't know if your city has a community pool, but let's just say it hasn't been cleaned in a while, and we just have stagnant water that just sits there. What's going to happen? If you have stagnant water that sits there, flies are going to come around. You might even have a dead rat in the pool, right? And stagnant water that doesn't move is going to start becoming grounds for bacteria and growth and mold, right? So your patient is predisposed to getting a pneumonia, an infection, with having this fluid that's not moving around. So we start your patient on antibiotics to make sure we're protecting those respiratory tracts, so that we're bringing down that inflammation. We're going to try to get that fluid out of the lungs and get that patient back into normal respiratory tract production, basically breathing normal. So another thing that we can do is turn your patient. Put your patient in 45 degrees, put your patient in 90 degrees, turn your patient at least every hour to make sure we're moving that fluid around, giving our lungs an opportunity to kind of poke its head out of the water, out of the fluid, and kind of take a breath. So if we're moving it around, we're facilitating, hopefully, drainage as we give our patients steroids. Another critical thinking aspect here. You, the nurse, you have a patient in Ards, late phase of Ards. Would you give diuretics or would you give IV fluids? Which one would you give and why? Bum, 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 bum. Bum, 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 bum. Well, the answer is you give neither. That was a trick question. So don't give IV fluids because your lungs are already filled with fluid. You do not want to give any more fluids that are going to add to this fluid-filled lung here. You're not going to want to give any diuretics because we are already having a trouble with perfusion. These diuretics are going to make your blood very concentrated, a lot harder to move that hemoglobin around in the body. So with very thick blood, not a lot of oxygen is going to be moving around, at least the oxygen you have left. Now, what you want to do, again, is antibiotics and corticosteroids. Prevent infection and decrease this inflammation so that that fluid doesn't progress into pulmonary fibrosis, into multi-organ dysfunction syndrome, MODS, and hopefully we can reverse this Ards in our patients, okay?
Lord mercy. I ain't linking nothing. Y'all are trying to get me fired. I see it. I see what's happening now. Thank you for telling me I'm not recording. Thank God I'm not recording. How long does it take a person to get... one other group of people. Actually, it's two groups. The really young and really old. How many of y'all know Mamaw Skeets? Y'all going to hear a lot about Mamaw Skeets this semester. From church. You know, she always has a UTI, right? How long does it take for these little ladies to get septic? Not long. Or babies, same thing. Okay, the other thing is a direct injury to the lung tissue. How do we do that? Somebody been vaping. What? Chest trauma? Get hit in the chest with a baseball bat? But that can put you at risk for developing Ards. Any damage to the lung tissue. So you have to be careful. All right. Some people just develop it. But like I said, the most common reason is they were septic. Look at that. Mortality rate, 46%. That ain't good. On the good-bad scale, that is not good. Because once you develop severe Ards and you go into multi-organ dysfunction, you're done. There ain't no coming back. And then he was talking about, would you give them fluids or whatever? You can't. Because from the sepsis, their blood pressure, you're going to have to raise that with medications. And we'll talk about that in shock. Well, I won't because I'm not teaching it. But you understand, you can't give them fluids because they're already overloaded. Their lungs aren't compliant. And you can't give them diuretics for the reason that he said. It'll coagulate their blood too much. You'll dehydrate them. Neither one of these is good for oxygenation. Plus, the lungs have lost compliance. Okay, we can identify those at high risk. We talked about that. That was the other one I forgot about. People on tube feedings. Aspiration pneumonia can cause you to end up in Ards because you develop the pneumonia, you get septic, da-da-da-da-da. So we have to check on our patients that are getting tube feedings. And we have to follow infection control. Because your patients that are ventilated, you have to do what's called the ventilator bundle to them. We'll talk about that when we talk about intubation, which is a series of protocols that your hospital will have to keep these patients from getting what's called ventilator-associated pneumonia. And you have to do it. Not want to, should, could, whatever, you have to. Because guess what happens if they develop ventilator-associated pneumonia? Their hospital visit's free. Because you gave them an infection they didn't come in with. What kind of infection is that called? Hospital acquired. What was the other name for it? Who? Nosocomial. HAI. Hospital acquired. HAI. Nosocomial. Did y'all hear? Never mind. We'll skip on that. All right, so what are we going to do? We're going to assess them. Okay, let me tell you this, and it will help you out. And you'll hear it from me probably more than once. Your assessment drives your interventions. You might as well get that tattoo. Because if you don't assess, you cannot intervene. It's just that simple. And once you've assessed, then you have to intervene. Because you can assess them to death. That patient has a blood pressure of 80/40. I'm going to keep taking it until it gets better. I'm not going to do anything else. I'm not going to give them no meds. I'm just going to keep taking their blood pressure. They're going to die. So you want to do that physical assessment. You want to identify those signs and symptoms. And there they are. Noisy respiration, cypernia. Cyanosis. What is cyanosis? Blue. What is pallor? So they're red, white, and blue, huh? No. What is pallor? They're pale. Y'all seen these people that come in? They look terrible. Their lips are turning blue. Their fingernail beds are blue. They're pale. They got noisy respirations. What are retractions? Y'all seen them kids breathe with their stomach and it's retracting and they're getting all this? Because they cannot breathe. What do you think their vital signs are going to look like? Somebody give me the blood. Somebody give me what you think their blood pressure would be. Up or down? We're not perfusing, right? What about your heart rate? What about your respiratory rate? When you got decreased cardiac output, increased respirations, and increased heart rate, that is never a good sign. Unless you're in love or whatever that causes all this. But when they come to the hospital and they look like that, that's never good. So we're going to do what? We're going to get some, we're going to diagnose them. We're going to get some tests. We're going to do a sputum culture, a chest x-ray. Why are we doing an ECG or an EKG? Huh? Who? Okay. They may be in dysrhythmias, but you remember we talked about heart failure? You know, if you have your patients in heart failure, what is their EKG going to look like? This is going to be non-cardiac. This isn't related to their heart. This is related to the non-compliance of their lungs. So what is they may be in sinus tach to rule it out. What is a lowered partial pressure of arterial oxygen? That is low arterial oxygen. The PA, y'all have seen it on your blood gases. It says PaCO2, PaO2. That's your partial pressure of arterial oxygen, your PaO2. It's going to be low. Why? Because they don't have oxygen in the arterial blood. That's why it's low. Why is it low? They don't have an exchange. Why? Y'all saw the picture of the guy with his alveoli. Okay, so if you've got alveoli full of fluid, can you exchange oxygen? Okay, that's the bottom line. Where the action is supposed to take place, ain't nothing happening. Because fluid has displaced the oxygen or replaced the space in the alveoli. What else is missing? If there's fluid around the alveoli, what else is missing? Think about your lung, A and P, back 150 years ago. Nope. Surfactant. What is surfactant? Who? It's a lubricant for the alveoli to keep them from sticking together, right? Huh? He didn't say that? I didn't either. I mean, what he said was really good, but what he wrote was... But if you don't have surfactant, your alveoli collapse. Well, if you wash all the surfactant off of your alveoli because you got fluid in your lungs, they stick together. and you got raisins hanging where your grapes used to be. Y'all are terrible. I'm trying to be like all serious and everything. But y'all know it's true. Because you think about it. Never mind, that video was rated NC-17. But you understand the concept of it. If your alveoli cannot expand due to the lack of surfactant and being full of fluid, you can't exchange oxygen. You are not going to get anything into the system to help that patient, and what's going to happen is you're going to see this change in their vital signs. And you're going to know because you're going to listen, and you're a good nurse, and you're going to say, ooh, this ain't good. I'm going to need some help. And then when you call them, you're going to say, I think we need this, this, and this. Why sputum culture? You have to identify the offending organism. That sounded fancy, didn't it? You got to know what's making them sick. Because why? Do all antibiotics work on everything? No. Do no antibiotics work on everything? Wait, yes. I'm confusing myself now. You do what's called a culture and sensitivity, right? If it's sensitive to it, does it kill it or not? If it's sensitive to it, it kills it. If it's resistant, it doesn't. That's why when you look at your little lab report and they've done this sputum culture, you're going to see a list of antibiotics and it's going to say S or R. Well, don't worry about the R because you're not going to give them. Unless you're an idiot. Look, don't be surprised. Because doctors have pet drugs that they like to give. If y'all don't believe that, you should. I know a doctor that every time they came in, they got Advil. My leg's broke. Get him some Advil. Actually, it was called Anaprox DS, which is double-strength Advil. But they get in love with these different drugs, probably because they're paying them, and they prescribe them, but they're not effective. Now, it's not as much anymore, but it used to be. So you've got to use this to identify what you can do to fix the problem. That's just like when you get a priority question. Y'all love that, don't you? The priority fixes the problem. A patient with pneumonia, what fixes the problem? The oxygen or the antibiotic? The antibiotic. So the antibiotic's your priority, right? Because I can give them all the oxygen I want until the cows come home. But unless I fix the problem, it's not going to matter. So that's how you get into this and you say, this is my priority because this is going to fix that patient's problem. That's going to make them better. Okay. Now we get to the fun part. All right, so we're going to intubate them, right? Because we've already given them the nasal cannula. We've already given them the simple face mask and the Venturi mask and the non-rebreather. And we ain't getting nowhere. So we've got to take control of their respiratory system. And it says PEEP, but I guarantee you they're going to end up intubated. Because that's the only way you can control their respiratory system. And you've got to be careful when you do it. Because if you don't, there's some problems when you put a patient on a ventilator that you can do more harm than good with them. You know, we always have to balance that out too. So, what kind of drugs are we going to give them? Okay, we're not talking about intubation now. We're talking about ARDS. What kind of drugs? Steroids. Why? Remember, he talked about it with his things. We're reducing the inflammation, right? Okay, so we want to do that. What else are we going to give them? Huh? We're going to have to give them antibiotics. We got to kill the bug. We want to make sure that they're eating. Wait, can they eat when they're intubated? Tube feeding. Or parental nutrition. Probably tube feeding because you won't want the gut to go limp, do you? You want to make sure that it stays rolling. Because one, if you don't, that's just another problem you're going to have to fix later. Because the body has already decided to shunt blood. It's not going to go to the gut. It's not going to go to the kidneys. It's not going to go anywhere else. It's going to go to the brain, the heart, and the lungs, trying to keep them to survive. And by doing this, you're forcing it to give a little circulation to the gut. All right. So that's our nutrition. Now, how many of y'all have ever helped with intubation? One. You never intubated anybody? Okay. Once or twice? Okay. So, this is an endotracheal tube. What do you need to put this down, that patient? An order. Okay. A blade. Like a switchblade? Okay. You need this. And before, this is like ancient because nobody uses these anymore. This is a handle and this is a blade. When you hand this to a healthcare provider, especially if you're working like at Chunky General Hospital, where they don't have the really new equipment, when you clip it on, can y'all see that really dull light? Make sure it has a light because that's how they visualize the vocal cords. All right. Also in this will be a piece of wire. I don't have one. Somebody stole it. Which is something you'll get used to, but you have to have it. It's called a stylet. When you put the stylet in there, you'll make a little loop right here. Do not let the wire extend past the end of this. Because what are you going to do? You'll poke a hole in your patient. Is that what we're trying to do? No. We're trying to make them better, not worse. Okay? So, what else do we need? Okay. Now, we would get it on film. We're going to do it this way. All right, so we're going to intubate you. Why? Because you're closer. So, the healthcare provider says we need to intubate. So I got my handle, I got my blade, I got my ET tube with my stylet. It's a pretend stylet, yes I know. I've got my ambu bag with a mask. Why? We're gonna hyperoxygenate her before we intubate her, right? All right. So what else am I gonna need? I'm gonna need a syringe. What am I gonna need a syringe for? To inflate the balloon. There's a balloon on the end of this. Remember, you're in Mississippi. A lot of crackheads. They got snaggle teeth. So you got to be careful, or it will cut the balloon. I've seen it. That boy needed some dental work in the worst way because the balloon wouldn't seal. Because when he went through, he had something that it cut him. It cut a hole in that balloon, and we tried to blow it up, and you'd go, shh, and you could hear the air escaping, and I'm like, redneck. So we had to re-intubate him. Okay? So then what? Need IV access, right? Why? For fluid and for what type of drugs are we giving? Sedatives and paralytics. Which one do you give first? Why the sedative? I ain't even going there. You do have to sedate a patient prior to paralyzing them. Why? Because when you are paralyzed without that sedative, you are fully awake, fully aware of everything that's going on, and you give that paralytic, you are going to spike their blood pressure because they have just lost the ability to do anything other than they can't even blink. Now think about that. A minute ago, you were struggling to breathe, and now you can't do anything. Your blood pressure is going to spike. Your heart rate's going to spike. It's just cruel if you do it that way. So you give them a sedative. Usually it's etomidate. It's supposed to be weight-based. I have never, ever seen a healthcare provider do this. It was always 20 of etomidate. Don't ask me why, but it's supposed to be, but they don't do it. It's because it's quick. So once you do this, they will relax. They got no choice. So you want a working IV, a good one. Once you do that, once you relax them, then you can administer the paralytic. They're not going to care at this point. They will go limp, which causes everything to relax to make the intubation easier. Now, instead of a blade, sometimes they'll use, this is called a glide scope cover. It is a video glide scope, essentially. So instead of looking down through their nasty teeth, they look up at a screen. That's the only difference. It just depends on what your facility uses. This is old school, this is new school. That's it. So once he visualizes, or she visualizes the vocal cords, because that's where this thing sits, is between the vocal cords, and the balloon has to go past them. You with me so far? Okay. We'll get to that in a second. He will say something cute like, "I'm in," or whatever. And either he or you will pull the stylet out. You will take a 10 cc syringe and blow up the balloon. What happens is the balloon, after it goes through the vocal cords, if this is the trachea and your vocal cords are here and this tube comes down through here, that balloon seals off the trachea. If this gets ruptured, air can go back out this way and you'll hear it. Okay? So whenever you do this, there should be no air passing. Now, after you've hyperventilated them before all this, eek. 2 points. And it shot me in the head. You can't put this on an ET tube. And you're thinking, that is the stupidest thing I've ever seen. Do you know how many times I've seen that done? Because this is what you've got sticking out of the patient's mouth. Is this going to make a tight seal? Y'all are laughing. But I've seen experienced nurses, because you are hyped up at this point, you're going, it don't fit. That's what you got to do. Now, once you do that, you will also connect. You'll breathe a couple times for them. Sometimes they'll do it right away. It actually takes about 3 breaths, but whatever. You will connect this to here, this to your ET tube, while it's still in the patient. And you will breathe in and breathe out. Breathe in, breathe out. This should change colors. This should change colors. What color is it now? Gold, yellow, take your pick. It will change, it'll change color to purple. It changes color to purple in the presence of carbon dioxide. What does that tell us? That you've got a certain amount of gas exchange, right? If I stick this into the throat and it goes into the stomach, is this going to turn purple? No, because you're going to have gastric content and you'll see their stomach start blowing up. All right, so you want that color change. It's imperative that you get that color change, because if you don't, you've got to re-intubate them. So, then what do we do? How many of y'all got a new stethoscope when you got into nursing school that you never carry around anymore? Well, what you do is you take that pretty little stethoscope out of your bag, out of your pocket, from around your neck. I don't care. You get the one off the bedside, and you listen while somebody bags that patient. Because what are you listening for? Breath sounds. Do we want them on both sides or just one side? Both sides. It's always important to have them on both sides. Unless they're a cancer patient with only one lung, and then y'all better not be documenting lung sounds clear bilaterally. Just saying. So we get that. Then what do we have to do? What if you only hear breath sounds on one side? Okay, we're getting to that. We're getting to the x-ray. But you have to ease it back. Why? It went down in one lung. You know, the anatomy is not, it's not a perfect Y intersection. It's kind of offset. So you get what's called a right main, and it will go into the right lung. Well, that's not necessarily a bad thing. You're still getting some air to them, but you want it to get to both lungs. So once you get equal bilateral lung sounds, or as good as you can get, they're gonna sound horrible anyway because the patient has Ards, right? Once you do that, then X-ray can come and shoot, because that is the definitive test for ET tube placement. Okay? Then you get your best friend in the world, who is your respiratory therapist, to bring a ventilator to you. And they will set it up. And they will have certain, we'll talk about some of the different settings that they'll have to get from the healthcare provider, but they will set it up, but you need to know what it is. Why do you need to know? So we can make sure it stays that way. Plus, you got to document it. Because then none of this happened until you document it. That's always our part. All right, so we got it in place. We got our x-ray. We're doing good. And we're intubated. All right? Now, we verify tube placement. We talked about that because it's going to do what? It's going to change colors. Here, you got to pass all this junk around too. Like I said, this is old school stuff. For a bonus question, what type blade is this? There's two kinds, a Mac or a Miller. What do you think? Who says Miller? Who says Mac? It's curved. It's a Mac. Why? Because an apple has a curve, right? It's shaped like an apple. A straight blade, that's how I learned in nursing school. Well, this is all we had. A straight blade makes an L, Miller. And healthcare providers are really strange because they'll want whatever they like, you know, whatever they used in medical school to learn how to do this. Here, I'll let you play with that. Okay, so now we've done all this. This is the definitive, right? But we want to make sure that we're doing this. And we don't want anything leaking out or anything like that. I'll let y'all want these too. If y'all want to, great. If you don't. And these are a one-time thing. You can't reuse them. So now we know our tube is in place, so we've got control, right? We can decide how many breaths a minute that patient gets, how much they get, how often they get it, how much oxygen is associated with it. And then we'll talk about a thing called PEEP, which is positive end expiratory pressure. And that's very important for your Ards patients. All right. Know how to contact intubation personnel in an emergency. You're in the ER. They're already there. Healthcare providers, tube placement, verification, tube stabilization. When those lovely, lovely, lovely people from respiratory come, because we used to do this with tape, they have the handy-dandy, no kidding, ET tube holders. It's Velcro. It's got a screw. Y'all have seen them. It's got a thing that you can slide it back and forth. Why would you want to do that? Mouth care. And what? You want to change places in the mouth, because if it sits right here all the time, what's it going to do? It's going to cause a pressure ulcer. Guess what? Now it's free. So you want to move it. It's all part of your bundle too. Well, not really, but you want to do it. All right, so we want to monitor for complications. Like what? What do you think some complications from this procedure could be? Who? We won't know that. Perforation. because you're going to get blood and other kind of fun stuff. What else? Pneumonia, aspiration, all that. Because we're going to have to be looking for all these complications after they've been intubated. Can you turn an intubated patient? You better. Because what are they? They're in bed. They're immobilized. Why? What else have we given them that we've started? Sedation. What kind of sedation? What's that white milky stuff that we like to give people? Propofol, the Michael Jackson drug. How many of y'all have ever had it? Really? That is the best stuff ever invented. Go for an upper GI scope. You get the best sleep in like 6 minutes. Because that's really all you're in there for. But you can see it. When that white stuff starts coming down that tube, and you go, ooh, this is going to be good. Mm-hmm. They shut you off like a switch. And then you wake up going, what happened? But anyway, you're going to put them on sedation. So you're going to have to do some other things. You're going to have to do sedation holidays with your patients that are ventilated. You're going to cut it off and make sure that they can still respond. Of course, you're going to cut it back on, too. Can y'all push propofol? Why not? You have to be a CRNA or a physician or healthcare provider or PA or whatever. So, we talked about this in professionalism. If they ask you to do it, just decline. You ain't got to be rude. Just say, look, that's out of my scope. All right. So we're going to talk about the ventilator types. They're always positive pressure. I'm not going to ask you about these. So we're going to go to the controls and settings. Okay. What is tidal volume? That is the volume delivered to the patient by the ventilator. And there's a calculation that you have to do, and I'm not asking you that either. Because you're not going to set these, but you're going to know what they are. But these are important, and I'll tell you why in just a minute. Okay, what's rate? Duh. How many times that ventilator will provide breaths for that patient? That's your rate. The fraction of inspired oxygen. Do we have oxygen hooked up to this? You bet your bottom dollar. We have to. Because remember, this is an Ards patient. They are not oxygenating. They are not perfusing. We are going to be probably starting at 100%, right? Because we got to get the bestest to these organs before they start going into dysfunction and failure. All right, peak airway inspiratory pressure. That's the highest amount of generated pressure by the ventilator. It's a setting to push the air from the machine into the patient. Okay? It's got to generate just like you do. You've got to inhale and you've got to create pressure inside to allow your lungs to expand. Well, that's what this does. Okay? So that's the maximum pressure. And when we talk about high pressure and low pressure alarms, these are important. Okay, positive end expiratory pressure, PEEP. This is the amount of pressure that stays in the line, keeping the alveoli from collapsing. Because if you don't have any PEEP, it's just like you breathing. Well, do these people already have a problem? What's happened to them? They're filled with fluid. What else have they done? Think about our raisins. They're collapsed. And they're sticky because they don't have any surfactant. So by doing this, we keep air in them. And they just can't collapse. So the next time they take a breath, they go, whoop, but they never go down all the way. Instead of going, I don't know if they make that noise when they do it. But this is what that Ards patient is going to have because of the damage to the alveoli. Now, a PEEP of 5 is kind of standard. That's where they most patients that come in that are put on the ventilator have that. But these patients have seriously damaged alveoli. It may be as high as 10 or 15. Now, you don't want to leave it there because you can injure the alveoli by doing that, but they don't have a choice. Their alveoli is so messed up with fluid and trash that's in there that they have to keep them open. And part of the thing is, because of all that fluid, their lungs are not as compliant. This is that old balloon that's been sitting out on the patio. It don't blow up and down like it's supposed to. It's got very little elasticity left in it. And the lungs are like that because of the fluid and all the garbage that's in them. So they have to be very careful with that, the airway pressure. Because if they put too much pressure, what could they do? They could pop a lung. They've got to be careful with the tidal volume for the same reason. If they put too much in there, it's not going to work because the lung will rupture. Well, have we helped our patient? No, he needs a lung transplant. Because we done popped the balloons up in his chest. The tidal volume, that's always managed by your ABG settings. Because if it's too slow, what do you think can happen? If we don't have them breathing enough, they can become hypoxic, right? So what's your CO2 going to do? It's going to build up. So if you've got a ventilated patient that's only breathing 6 times a minute, what do you expect their CO2 to do? It's going to go up. Y'all remember that from your ABGs? The hypoventilated patient? Same thing. What about your patient if we set the rate at 37? They're going to become what? Why alkalotic? Because they've blown off all their CO2. So you can adjust your ventilator settings based on your ABGs. That's what the healthcare provider is going to do. So when you get those ABGs and you take a quick peek at them before he does, and you've got a patient that's either hypoventilating or hyperventilating, you can see it on the ABGs. You can say, look, we may need to back off on the rate. Or we need to increase the tidal volume. Or we need to do something. But you've got to be aware of what and why they're doing it. Always assess the patient first, the ventilator second. Do we take care of ventilators? Do we take care of blood pressure monitors? We take care of patients. Monitoring the patient's response. How can we tell if this is working? Their ABGs are getting better. What else? Their sounds are getting better. Now, the ventilator will not cure Ards. This is just a means to keep them alive. But what else are we doing to them, for them? We're what? We're breathing for them. That's always a good thing. That whole breathing thing is pretty important. If you don't believe me, go underwater. But we're giving them what? We're giving them antibiotics. What else are we giving them? Steroids. You think we can give them breathing treatments through a vent? Absolutely. Anything that we can do to increase oxygenation. So how can we tell if it's working? Their oxygenation gets better. All right? So let me talk about the alarms real quick. A high pressure alarm for a ventilator is triggered when the ventilator is having to use more pressure than it's been set at to get air into the patient. What do you think could cause that? A kink in your ET tube. What else? The patient's fighting against the ventilator. What can we do about that? Sedate them some more. We got to be careful, though. What does sedation do? What can it do to your blood pressure? Hello. It'll tank it if you're not careful. Coughing will do it. What about this? Y'all will never forget that now. Biting on the tube. a kink tube, all that. That means that it is having to generate too much pressure. And I wish I had a ventilator to sound the alarms because they're annoying. What do you never, ever, 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 ever do? You can silence it, but you never shut it off. Okay? What about a low pressure alarm? That means that it doesn't have, there's no resistance. I mean, it can just go whoosh, and you'll hear it. The biggest reason that you have a low pressure alarm is a disconnection somewhere in the circuit. Because it doesn't have to generate any pressure. It's just flowing out there. So either your balloon has ruptured, it's deflated. When you inflate the balloon on an ET tube, this is called a pilot balloon. You can squeeze it. If this is inflated, so is this. If this is flat, so is this. So when you do your assessment, notice I use that word again, you check the balloon. And notice there's little things on there that say, there's numbers somewhere. I can't read them, but that's all right. And you note that. And they'll say at the teeth or at the lips, I prefer the teeth or the gums. Why? They don't move. Y'all seen these patients that stay in the hospital and everything swells on them. Well, how do I know if that's right? Well, if I measure at the gums or at the teeth, they ain't moving. But when I do my assessment, I have to note that. When I do my assessment, I have to note it whether or not that balloon is inflated. Well, how can I tell? Well, I can tell, one, because air ain't getting out. It's not going and I'm getting this low pressure alarm. Now, you're supposed to check the inflation amount with a manometer. Who's got a manometer? I don't even think they have them at the hospitals, but it'll tell you exactly what the pressure is in that balloon. Why would you not want to overinflate it? Who? Well, so it doesn't pop. What else? No, it's already through the vocal cords. The balloon is below the vocal cords. It can cause erosions of your trachea. Because if you don't believe it, take your finger and squeeze it and hold it there for about 3 days, and your fingertip will turn black. Why? Because you cut off all the circulation to it. Well, the same thing with that balloon against the esophagus is going to cause that tissue to die around it. Well, then what's going to happen? You're going to start getting a low pressure alarm, but then you're going to have an ulcer on the inside of the patient's throat. And that's probably not a good idea either. Does this make sense? Any questions? Y'all even know what to ask? Are y'all brain dead from the test? Yes. Dang, I hate that. Well, we got to keep going. All right. The other complication is we talked about ventilator-associated pneumonia or ventilator-associated events. If you look in your book, I know I highlighted it. Why? Because I had to. There's all kinds of stuff in your book. Is that where it is? Well, that's your alarms on 603-29.5. But if you look on page 605 in the left-hand column, it says to prevent VAP, which is ventilator-associated pneumonia, implement the ventilator bundle order sets, which typically includes these actions. I would highly recommend that you know these. Not only for your test, but this is how you're going to keep your patient safe. What does it say? Keeping the head of the bed elevated. Why? Because where do secretions want to go? They want to go down. We don't want them going up. .605. Keeping the head of the bed elevated at least 30 degrees. Performing oral care per agency protocol. So you're going to get all kinds of weird things. And that means keeping their teeth clean, either with those little lemon swabby things or a chlorhexidine brush. And usually that's done once a shift. Now, that's not in your book, but chlorhexidine needs to be done at least once a shift because that's going to eliminate the bacteria in the mouth and keep it from, because if you got that stuff sitting there, it's going to develop. You need to keep that area clean around that ET tube. You want to wipe their face too. And use a different washcloth than you use to wipe their butt. If y'all didn't learn that in first semester, I swear to goodness, I've seen one person use one rag on a patient. It wasn't one of mine. And I was thinking, do you do that at home? You got the Zackleys. So you want to use that chlorhexidine to keep the bacteria from forming in their mouth. The other thing is ulcer prophylaxis. What is that? Prevention of what kind of ulcer? Stress-induced hospital ulcers, right? So what are we doing for them? Who? Say it loud. Protonix IV or pantoprazole. Canadians. We have to give them that. We have to do pantoprazole. What else are we going to do for them? Preventing aspiration, pulmonary hygiene, including chest physiotherapy. What is that? That's where respiratory comes in and beats on them. Okay? Some other things. Now, since we got them sedated, intubated, they are our best patient. They ain't asking for nothing. They are not on a call bell, but they still got needs, right? So what else? Now what are they at risk for? Skin breakdown. Oh my God, are we back to skin breakdown? Wasn't that first semester stuff? We don't need to know about it. We trauma nurses now. Nope. Nutrition. All that kind of good stuff. You want to turn these patients. How often? See, it don't change. What else are we going to do for them? What are they at risk for? We want to keep them clean because we don't want no butt breakdown. We want to suction secretions if they need it. They are at risk for DVTs. We're going to put them STD hose on them. We're going to put them other things on them, them white things that nobody can get on a patient. Who? Over their face? Oh. That's right. You can put a plastic bag over their face. They ventilated it. No. Yes, I know they're SCD hose. But my instructor back 157 years ago when I went through nursing school called them STD hose, and I've never forgotten that, so I just use it every year. STD hose. It's kind of a theme, but whatever. All right, so these are all the precautions that we're going to have to do. We got to turn them. We got to clean them. We got to do the ventilator-associated pneumonia bundle or the ventilator bundle. We got to make sure that we're preventing blood clots. What else do we got to give them? Blood clot oriented. We got to give them a blood thinner. What are we going to give them? We can give them heparin. We can give them enoxaparin, whatever. But as long as we're doing something to prevent these blood clots. Because now they're immobile, right? And now you got all your hazards of mobility. What else we need to do to them? You can always do range of motion. That's going to help prevent the blood clots. What else we got going on? We got their blood clots. We got their skin breakdown covered. We're keeping them clean. What kind of stool you think they're going to have if they're on liquid thingies? Liquid. And they're going to do it every hour on the hour just to ruin your day. Who said it? That's right, Sugar Bear. We're going for the BMS, the bowel management system. It does not work with hard stool, but it does work with liquid. It's something that we can do if they're having issues with it. What else? We're going to put a Foley in them. This is one of the few times when it's recommended. Because with this, we want to make sure we're keeping accurate INOs, right? And it'll also help them keep them dry. How many of you have seen that Pure Wick thing that they're using on these incontinent women now? Or men? I don't know if they use it on men. They do, really. Those things never work. You got to duct tape them things on. Oh, are they? If it moves and it ain't supposed to, duct tape. Because they're going to lose all the hair anyway. Ow. No, so you want a catheter in this patient. Okay. And that's just something else that you're going to have to deal with. All right, the other complications are cardiac problems, because if you can't manage their electrolytes, they can develop dysrhythmias. Lung problems, GI problems, infection, muscle deconditioning. You're going to have to do that passive range of motion. They may become dependent on the ventilator to breathe. This is a problem with like your COPD patients. So if they've got a history of COPD and now they're an Ards patient, you're going to have trouble weaning them off the vent. So you have to be mindful of that. You need to get them off the vent as quickly as you can. It's just like everything else. The longer they stay on it, the harder it is to get them off of it. Okay. Volume trauma, especially with an Ards patient, too much volume will cause injury to the lung tissue. Volume trauma, no, the barotrauma is from too much pressure. The volume trauma is from too much volume, and it can injure the lung tissue. So the image, okay, they had an Ards patient and they were getting positive pressure in ventilation. That's the only kind we're talking about now. You see how this has that ground glass thing right there, but you do have air here. That's done. Okay? The other thing is, we talk about positioning your Ards patients. What's the best position for these patients? Prone. Why do we prone them? Not prune, prone. Say it loud. Your lungs are on the backside. Where does fluid like to settle? At the bottom. So if we flip them, actually you don't flip them like that, you flip them like this. What it does is it pulls the fluid to the front and it allows you to recruit the alveoli in the lungs. Because if it's up here, you've got more on the backside that you can try and get oxygen to. Now, you don't leave them prone, but it's something that you're going to have to do. You're going to keep them up. You're going to have to prone them. You're going to have to move these patients. Now, you got a tube coming out of every orifice, and you've got different wires, IVs. Get some help before you try and flip these patients. But what happens if you pull, like, the ET tube up, or it comes off the ET tube? What do? Put it back on. It's ain't rocket science. If it pops off, put it back on. Well, what happens if I pull the IV out? Start a new one. Whatever you take off, you got to put back. Now, if you rip his Foley out without deflating a balloon, you got a whole mess you're going to have to deal with. I ain't talking about that one. So just be careful. Get help. Extubation. We're going to hyperoxygenate, thoroughly suction, because we don't want any stuff going back down. We're going to remove the tube during exhalation, instruct the patient to cough, and then we're going to have to provide oxygen for them and monitor them. Now, we're not going to go through the weaning process because that's not what this is about. We just want to get them out off the ventilator. But the hyperoxygenation is pertinent. The suctioning, rapidly deflate the ET cup. I forgot about that. We're just going to try and pull it out with the balloon still inflated. That's going to be fun. It'll almost pull their head off. And you'll see patients that will extubate themselves. They call crazy. All right, it is break time again. Thank goodness.